A very warm welcome to all of you. As we launch the Global Indian Physician COVID-19 Collaborative, let me on behalf of everyone invite Dr. Prathap Reddy. Dr. Prathap Reddy is the founder, chairman of Apollo Hospitals Group. He's the founder, president of the Global Association of Physicians of Indian origin, widely recognized as the architect of private healthcare in India, has made immense contribution to the way healthcare is practiced in India today. He's a recipient of many awards, the Padma Bhushan, the Padma Vibhushan, to name a few.
We are now witnessing World War III, a war that has engulfed more than 200 countries and territories in just 100 days, infecting more than 1.6 million people and taking away the lives of more than 900,000 lives. I'm now saying that the world as we see it, we know it, will never be the same. I'm 65 years as a doctor now, that the world as we know it will never be the same. In my 65 years as a doctor, I've never seen what we are seeing today. SARS-CoV-2, a 120 NM virus, has brought the world to a virtual standstill. It has made us pause, stop, and think. It has made us realize that the world we live in today has no borders. It has brought such a great distress to the world. It has made us aware that we as a human race can break the barriers that we have erected, and as a united force can take the challenge to stop this.
She is a psychiatrist by training, and she is the 174th president of the American Medical Association. She was appointed in June 2019. She has diverse experience as a private practicing physician, a public health administrator, and a patient advocate.
As been said, the coronavirus pandemic presents a challenge that I hate to use the word unprecedented. Sometimes it's overused, but we have not seen in a couple of generations. And we know, unfortunately, in the U.S., everywhere cases are climbing. Certain places cases have decreased, but then are on the increase. So there's so much we don't know about this virus. But in the U.S., our cases are climbing. Deaths are mounting, again, in physicians, nurses, all of the healthcare workers. And actually, not just the healthcare workers, those who are driving buses and cleaning our facilities are on the front lines every day, working long hours under intense pressure, and sometimes, unfortunately, dangerous conditions. And we know, of course, that is happening all over the world. The toll is staggering. We all know that we are not going to be able to flip an on switch. It's going to take some time. And again, that's working together globally before we get back to what I say is a new normal. We will not get back to the normal pre-COVID-19, but a new normal.
Thank you so much, Dr. Harris. And I could just see that Professor Vinod Paul has joined us. Thank you so much, Vinodji, for joining. And you've led the charge for 1.35 billion people. We're really proud of the way you've worked 24/7 over the last few months. And in fact, you started very early in January, long before India had its first case. So over to you, Professor Paul.
I would also like to emphasize that our journey is not only to address the problem in this manner. We are also looking at a very major COVID-19 R&D mission, research and development mission. We have a strength in this area. We have a very vibrant industry, biotechnology and a pharma, and also to an extent biomed devices industry. We have a plethora of laboratories in the space of Indian Council of Medical Research, the Department of Biotechnology, Department of Science and Technology, Council for Scientific and Industrial Research. There's a plethora of national laboratories, and we have mounted a very concerted effort. And I'm pleased to tell you that at least 3 Indian diagnostic kits have been placed in the market. I'm happy to tell you that there are 4 vaccine candidates in at least 4 of our laboratories. I'm happy to tell you that our industry is already working with collaborators outside India to take forward 4 potential vaccines.
Moving on, we now go on to Dr. Bobby Mukkamala. Bobby is a board-certified ENT surgeon, a head and neck surgeon, was elected to the American Medical Association Board of Trustees in 2007. He's been very active with AMA since his residency and now serves as the secretary of AMA. Over to you, Bobby, and Bobby's going to share his perspective.
So here in Michigan, my home state, for example, the latest statistics are that we have 22,000 COVID-19 positive cases and 1,200 deaths as of yesterday, just in our one state here. The vast majority of those cases and deaths are in the Detroit area, which is our metropolitan center, and extending out from that metropolitan center into where I live, which is Flint, which is about 60 miles north of Detroit. So these are urban areas with large underserved populations. And I think as we see data from around the country, we will see a disproportionate effect of this infection in these underserved populations.
We now move on and bring Dr. Sudhir Parikh in. Sudhir Bhai is a renowned specialist in allergy and immunology, practices in New York. He's been honored with the Padma Shri, the Knight of St. John's, Knight of Malta, and the Ellis Island Medal of Honor. He's currently the Secretary General. Over to you, Sudhir Bhai.
Good evening to everyone. I'm coming from the epicenter of this COVID-19 in USA. And a lot of our colleagues and friends, and particularly Indian Americans, physicians are in the front line. They are working hard and against all odds. Luckily, now in New York and New Jersey, the curve is kind of flattening. Number of ICU admissions are less, number of discharge are more. So that's some good silver lining in this epicenter of New York, New Jersey.
I'm going to invite our dear friend, Dr. Suresh Reddy. Suresh is the dynamic current president of the American Association of Physicians of Indian Origin, very well known as AAPI. He's the 36th president. Suresh is a neurointerventional radiologist, and he's been instrumental in putting this collaborative together.
Today, I'll be talking about the next 2 weeks. I think the next 2 weeks, the game changer. I honestly believe and pray that the convalescent plasma is going to be the game changer. So we already established a committee, a team from AAPI called AAPI COVID Plasma Donor Committee, which is working very hard, extremely hard, along with the Red Cross. And our role at this point is collecting the database, the donors and the recipients, and working with Red Cross and complementing and facilitating their actions. We also requested the President of United States and sent letters to all the governors of all states to establish more and more centers in all the major cities in United States and make all the medical centers in United States accredited to administer this plasma. And there are several protocols going on. I think the most popular one at this point is the Mayo Clinic.
Professor Kamlesh Khunti from Leicester. He's a professor of primary care, diabetes and vascular medicine at the University of Leicester and director of the Leicester Diabetes Center. His work on multi-ethnic screening risk for diabetes has significantly influenced the content of important guidelines that have been adopted in the NHS. He's a senior advisor to the Department of Health, advisor to NICE.
This has already been mentioned. These are quite exceptional circumstances. So the first data we started seeing for COVID-19 were from China, Spain, and Italy. And as you know, these are very homogeneous populations. So we weren't seeing any ethnicity data at all. UK has one of the most diverse multi-ethnic populations. 14% of the UK is Black minority ethnic populations. And we started hearing reports of this about 10 days ago from friends and colleagues phoning me and saying, Kamlesh, you're the man for data. We're seeing more South Asian at a younger age in intensive care units. So we started tweeting this about this. And we were basically by a number of people told we shouldn't be doing this because we are alarming the population. However, fortunately, last Saturday, the first report from the intensive care units came out, showing that South Asians and Blacks were disproportionately affected. About 35% of people in intensive care units were of Black minority ethnic populations. And as I mentioned, that 14% of the UK is of BME population.
Sanku is a distinguished gastroenterologist, practices in Oklahoma. He was a former president of AAPI and was the second president of GAPIO. Over to you, Sanku, and some perspective on GI issues that you're seeing, because when we first started off, it was all chest, and the focus really was on pulmonology, but then it became evident very soon that GI symptoms were very important. And of course, now we know that shedding in the feces carries on for way longer than it does from the respiratory tract. So over to you, Sanku.
I've been a physician in practice for almost 51 years, and I continue to practice clinical medicine full-time. Having said that, the GI symptoms are the common ones. Let's get over with it. Is nausea, vomiting, abdominal pain, diarrhea, alternating in taste. But it rarely presents with GI symptoms. That's a takeaway point. In SARS-CoV-2, it has been postulated and observed that the virus stays in the nasopharynx for 2 to 3 days before it starts invading into the bronchus, into the lung tissue. So you do have a hiatus of 2 to 3 days. It has, in Wuhan, it has been noted that every family in such a big city has at least 1 or 2 family members with this virus, still stay with them, but the rest of the family does not get it. Apparently, they follow a very simple technique that they have warm salt water gargling 3 to 4 times a day on everyday basis. So there's something takeaway message if that helps. Now, fecal shedding of the COVID-19 RNA virus is seen in the stool. It continues, as Anupam said, for several weeks after even recovery, as much as 17%. The clinical implication is not known. However, we have to keep it in mind that using public toilets to be avoided or sanitized before using.
So we go back to the UK, and Ramesh Bhai, would love to hear your perspective. But globally, we've been very concerned about the high-profile, individuals who've been infected in the UK. So tell us, how is the Prime Minister and how's the Health Secretary, and then give us the UK perspective, please. Over to Ramesh Bhai.
The news about COVID is not really very good in UK at the moment. The number of cases of COVID are still rising, and yesterday we had 70,000 positive cases and total of 8,958 patients died. So large number of deaths. However, according to the health minister, there are signs of curve flattening, but it is clear that the virus is still spreading in the community. The unfortunate thing is, so far, 32 of healthcare workers have died while working in front line. 14 of these were doctors, and all these doctors were from Black and ethnic minority community. Professor Kamlesh has been talking about this issue, and we have written to the Department of Health, and we have offered our assistance to see why this is happening. And once we know why this is happening, we can think of what preventive measures can be taken.
He's also the founding member of the Canadian Physicians with Interest in South Asia and the Canadian Association of Physicians of Indian Heritage. Arun Bhai is going to talk about integrative medicine and COVID. Over to you, Arun Bhai.
My very short remarks are to look beyond current acute crisis. It will pass. Friends, it will pass. We will have another one of tsunamis of chronic diseases, which is not too far. We should plan long-term sustainable solutions for these problems. We must prepare for a long-term fight against invisible enemies like COVID-19 by influencing one's immunological age. Biological age and chronic age is integrated with immunological age. Science of yogic principles, which emphasize healthy nutrition, de-stress, physiological exercise, and breathing are part of integrative medicine. Best of East must be combined with West of West. Should be incorporated in our toolkit as we go forward. Specific drugs, vaccinations, and other interventions should work in tandem with lifestyle interventions for sustainable solutions.
Now we come back to India and we move to Bangalore, and we have Dr. Nandkumar Jairam. He's a professor and head of the department formerly at St. John's Medical College in Bangalore. He is the chairman and group medical director for Columbia Asia Hospitals and is the vice president of GAPIO. We're requesting Dr. Nandkumar to share his perspective on the psychological issues that are bound to crop up when we actually face a pandemic.
I would believe that there is one aspect that may be a little divergent from what has been discussed until now, and that is the psychological impact this disease has had and will have on several aspects of society. The general population is affected substantially with several aspects of worry. Whether or not they would succumb to this virus, would death hit them, are specific concerns of society. For people and patients who are in isolation, there is a concern of isolation itself, of remaining in isolation or moving to a more critical area, which is also of profound importance. Doctors are psychologically impacted. The impact is because of a complete changed environment, of loneliness because they have long hours away from family, and also the fact that they themselves may be victims of this disease. It is therefore important that while we as a community work towards a solution and control this condition in one way or the other, that we also address this as we move on individually and collectively for the welfare of humanity and for ourselves.
Anju is a gynecologist with special interest in laparoscopic surgery and fertility. She has been Vice President and past Secretary of the Australian Indian Medical Graduates Association, or AAYOG. Going to request Anju to share the Australian perspective. The numbers in Australia haven't really gone up, and we would want to learn on what worked well in Australia.
Some early encouraging news from Australia. Our numbers as of now are total cases 6,298 and 56 deaths. And here is how we have done so far. Australia being an island, we got natural advantage. We closed our borders and started quarantine relatively early. Our growth factor is less than 1 with minimal community transmission at this stage. Our per capita testing is second highest in the world, around 1.3% of population, and it is increasing. Our positive tests are lowest at 1.9%. And recently we started rapid COVID testing with results within 1 hour. We are using HIT model of care in which is hospital in home. It is for mild cases staying at home and closely monitored by health staff. ICU beds have been increased significantly, and all private hospital ICU beds have been taken over. War is not over yet. We are working hard with the rest of the world in finding treatment options and immunization. Not long ago, in 1981, diagnosis of AIDS was like end of life. Now, a person with HIV can live a normal life. Together, we can win COVID War too. Thank you.
Sudhir is a gastroenterologist, practices in Georgia, and he's the president-elect of AAPI for 2021, and he's going to talk about liver issues. So over to you, Sudhir.
You all know that novel coronavirus is an RNA virus, single-strand RNA virus, and it replicates by using RNA-dependent RNA polymerase. And it binds to internalize into target cells through angiotensin converting enzyme 2, which is present in the biliary and the liver epithelium. And the liver is a potential target because of this infection. Most of the time, COVID patients come with some mild abnormal liver enzyme, that is AST, ALT, and sometimes bilirubin. And if any patient of COVID we have a low albumin, it shows that the cytopathic effect of COVID virus. And coming to the drugs, most of the drugs, especially the experimental drugs they are using for COVID, remdesivir and tocilizumab, can have enzymes can go up. However, you should not stop these drugs. We can use it with careful monitoring. Other drugs like hydroxychloroquine and Zithromax is less toxic to the liver compared to other drugs. Coming to the chronic liver disease patients and the liver transplant patients, patient waiting on transplant, if they have a COVID infection, they are not transplanting at this time, WHO guidelines. And patients have chronic liver disease, a non-transplant, they discourage not to travel and also avoid frequent hospital visits. And most important thing, there is no recommendation not to change immunosuppression at this time. And whenever these patients present, they should look for other etiologies like hepatitis B and C and autoimmune hepatitis before you jump into the COVID.
We now go over to Manitoba in Canada, where we're going to be joined by Dr. Sunil Patel. Sunil is a family physician in Manitoba, was founding president at the Canadian Association of Physicians of Indian Heritage. Over to you, Sunil.
In Canada, we have 22,147 cases as of today. The majority of those, 18,000, are between Ontario and Quebec. We can attribute these to unrestricted travel from overseas, arriving the two hubs, Toronto and Montreal. In contrast, British Columbia, where Dr. Garg is, has fewer cases and doing very well. The curve seems to be slowing. In Manitoba, with a population of 1.3 million people, we have 230 cases and 4 deaths so far. And that really, I think, comes about because of social distancing. And we are really in unique and unprecedented times as we face this once-in-a-lifetime pandemic of COVID-19. Countries such as India, who have chosen to take extreme measures, are beginning to show results. So until we develop a vaccine against this new virus or find new treatments against it, we must engage in measures that prevent the spread of this unique and deadly virus.